Sure. So I think there are a couple different components I'll talk about. First is the issue I talked about in my talking points in terms of us stratifying the HEDIS data starting in 15-16 by different demographic factors. So currently, we haven't decided yet who will do it. We have a RFP out right now for our external quality review organization, which is the independent entity that the federal government requires us to have to audit health plan HEDIS and other types of data. So we may have our ECRO do it under the new contract, or the department may do it internally. We're just making final decisions as we move forward to finalize that contract, but we'll do it in 15-16. Also through our Section 1115 Medicaid waiver, many of you are aware that we are looking quite a bit at data integration, information sharing, data analysis. So that information would be done within, or that analysis would be done within the department as well, and obviously are still working to build that out and are in discussions with CMS. But to get to your question about what do we do with the data, it really varies depending on if we see that there potentially is an issue with one health plan, or if we see if there's an issue across all health plans within a specific health plan model. So it varies, but what we do start by doing is providing technical assistance. So that's providing information in terms of what does the literature say. It's about pulling together our health plans and talking about best practices. For example, right now, Contra Costa Health Plan, I talked about the overprevalence of Black women not getting postpartum visits. Contra Costa Health Plan is one of our health plans, and they're currently going out and interviewing community health workers to find out how can we better work with that population and get them in for postpartum visits. So it's really about looking at what the root cause analysis of the data is. So where is the issue located, what's driving that issue, and then how do we identify those best practices to drive improvement. And that really can be broad, as I mentioned, in terms of just looking at the literature, talking amongst health plans, working with our national partners, but then also monitoring. I mean, that's the key component, right? So we identify the issue, but we also need to be looking from the baseline and as we move forward at kind of what are the changes, and looking at it in a rapid cycle quality improvement manner. So not, I think, usually with HEDIS, it's a 1-year reporting period, but we want to be looking throughout the year to see what's happening, how is the population responding to the implementation of the effort, and then modifying it as needed.
Okay, so when you look at, let's say, various health plans to see if it's one versus the other, if it's a COES, and if you find that there are specific areas, which I'm assuming that it's going to be, the areas of the greatest need, are poor communities, I mean, everything we saw up there with regard to the data, is the state willing, or is the administration going to look at putting more resources into those areas to make sure that the disparity is there's more equity? I mean, so let's say you have two plan health model like LA, but both health plans are showing that in Compton there's horrible health results. Well, there's less providers. So knowing that, are we going to go ahead and now put more resources to make sure that we get some more? I mean, is that where the administration, I think, is going to go at that point or not?
Well, definitely under the Section 1115 Medicaid waiver renewal, that is what we're looking at. So we're asking the federal government, as I mentioned, for $15 to $20 billion, and are looking at reinvesting money from savings, but also using some of that money to incentivize our plans, and through them our providers, to both expand and add new providers into Medi-Cal through workforce development, through training of different types of providers, and adding new types of providers that potentially we haven't used in the past, like community health workers, but also looking at if there are ways to incentivize things like data reporting and collection, and information sharing as well. Okay.
Follow up from the last presenter with the readmission, and then the fact that California is one of, I believe, 14 states that gets fined for the readmission policy. Is your department doing anything to address that, to help the safety net hospitals whatsoever?
So in terms of all-cause readmissions, we currently have a quality improvement project, or a QIP as we call it, that's in its third year that our health plans have been implementing. Under our new ECRO contract, we'll likely be modifying that work, but we are working with them with the health plans to work to decrease avoidable readmissions. In terms of working with the safety net hospitals, I think that that's more related to the work that we're looking at doing under the DSRIP in terms of the waiver.
Okay. And then to Mr. Lee for Cover California, you had mentioned now you're in the process of looking at all the data from, comparing what you do as like CalPERS being a large purchaser. once you have that data, obviously you're going to try to control costs, make sure that the disparity issues are addressed. So the question I have for you, is there a way that the legislature can see that as well? Are you going to share that with the legislature? And is that within, and I don't know if that's something statutorily we have to ask, or, what's the process? Because I think that's valuable information that we need to look at.
No, we are phenomenally transparent, and so we will be making this data very public at a plan level. A lot of this, for the data analytics I'm talking about, is this is a year out in terms of getting this, but this is something that we think is all of us should be having, and including consumers, as they make their choices. So this is not something that's going to be behind closed doors.
Perfect. Okay, I don't have any other questions. I want to just take this time to thank all of you for being here this afternoon. Very, very informative. It helps us and me determine policy, what we're going to do as we move forward to address this very concern. Any other questions or comments from any of the members? None? Seeing none? Yes, comment?
I just want to thank you all for your participation. Thank you for your commitment to collecting and gathering more data that can inform the steps that we take going forward. And I just want to thank the Deputy Director Miller. I thought that your presentation was particularly compelling. In a couple of those slides, it just presented such a stark set of data that was just, I thought, very helpful. And I think here in the legislature, we're all committed to data-driven, evidence-based solutions. And we need to get the right data and the right evidence first before we can drive those solutions forward. So I want to thank you all for your testimony today, to your commitment to this area, and I look forward to continuing to work with you.
Thank you very much. We're now going to move on to item number 5, public comment. Those of you who wish to, I appreciate if you'd come up to the microphone here, state your name, who you represent.
Good afternoon, committee members. My name is Maribel Castillon. I am a public health nurse for the Child Health and Disability Prevention Program in Los Angeles County. In California, it is estimated that annually 1.1 million low-income children and youth between the ages of 0 to 20, which is the next California generation, receive well-child CHDP exams, which include preventive services from medical providers who participate in our program. One of the challenges I see within the population I serve is lack of accessible resources for undocumented patients requiring specialty care. For example, if an undocumented child is diagnosed with a condition needing specialty care, like dental, vision, or any other health condition like a heart murmur, by one of our CHDP providers, she or he is required to refer them to a county facility because no one else will take them. Because of the overwhelming demand, obtaining an appointment with a specialist can take anywhere from 3 to 6 months. I have also seen a decline in patients not keeping their appointments with the specialist since the implementation of the state's policy of cost sharing. Many families can't afford to pay the services and choose not to pursue the referral. As someone who has used LA County services as a teenager, attended and trained at LA County School of Nursing, and has served as an LA County employee for more than 17 years, I know our work is world-renowned. We can continue to make a positive difference in improving healthcare if state policies focus and invest in safety net facilities. Thank you very much.
Thank you. Next.
Hi, good afternoon. You want to go? Okay.
You're up. State your name.
My name is Frances Todd. I am a pediatric nurse practitioner at Harbor UCLA Medical Center, and I have been there 40 years. The last 25, and please do not do the math, it is about a quarter of a century. I have been working with premature infants and sending them home, and insurance coverage is actually one of my prime functions, is to make sure they have the coverage that they need to get the premature infants up to where they need to be successful in first grade. During that time, I was fortunate enough to work with many different ethnicities. Most notably, in Carson, California, we had the largest Samoan population in the world, even more than in Samoa. Okay, LA County has always prided itself in developing a special type of safety net provider that serves centers of excellence in all areas, but most notably in trauma care, pediatrics and neonatology care, and specialty care to this high-risk population. The managed Medi-Cal population that we serve, that's a certain portion of the safety net population, often has been sent to us because they are a higher cost, both socially and medically complex families, not just patients, but families, especially dealing with children. You have to get the family involved or your healthcare goals are not going to be met. The benefits beyond just providing the health care to this segment of the population is that all of the county facilities train all levels of community providers for health care, from nurses to CMAs to interns, residents, fellows, and the attendings that are at our facilities are world-renowned and do some absolutely phenomenal research that changes healthcare for the entire world. We cannot even begin to address the issues of healthcare disparities without making sure we have a strong, financially sustainable, and that's the key words, financially sustainable safety net system. And by the way, Dr. Hernandez, my zip code is 90744, and I do vote. Thank you.
No. Hi, my name is My name is Sheila Altamar, and I'm a registered dietitian. I work for a safety net institution. I work for Santa Clara Valley Health and Hospital Systems, and I work with prenatal women that have diabetes, and I'm here as a voice for them. And the one thing that I would like to discuss is preconception care for our moms with diabetes. And I mean, it's a fact that preconception care decreases adverse birth outcomes. And studies have shown that also with preconception care, that it yields billions of averted costs. The problem is that the women that need that care, the care is not covered by Medi-Cal. So if we're talking about prevention and we're talking about diabetes, then we have to talk about preconception care. The second thing that I'd like to speak to about my moms, as I call them, is that they have a very hard time with their clinic appointments. So because the clinic can only charge for one appointment per day, my moms end up coming sometimes 2, 3, 4 times a week. A lot of them have to come on the bus. They have to bring their children. And then there's my moms that at work, and they can't take that much time off from work, and then they end up not coming to their appointments. If they could, if the clinic could charge for multiple appointments for one day, so that my mom could take one day off and have all her needs met, that would be very, very helpful. And then the last thing, just kind of a note, is when you're talking about team-based care, I think that it's a really good concept. I think you have to remember the mental health workers, the drug and alcohol counselors, social workers, and dietitians. And you can talk about it, but if those services don't get reimbursed, then that means the hospital's not going to be hiring that staff, and that service is not going to be getting provided. So just if you could keep that in mind.
Thank you.
Thank you.
Who's next?
Hey, my name's Gary Poe. I'm an organizer at St. John's Will Family Center Clinic in Los Angeles. I'm happy to report a patient by the name of Carol James who has diabetes. Now she has access to her medication and now frequently see her doctor for preventive care and her yearly physicals. This type of safety net has actually brought down the number of emergency visits. And it has risen the patient and doctor's relationship in neighborhood clinics like St. John's Will Child and Family Center. Lately, Ms. James needed a surgery, gastro bypass. She was referred to a specialist. Her appointment was more than 2 months out to get to this surgery that she so much needed. I could only think about the pain of a patient waiting 2 to 3 months to get a surgery, that's critical to her life. And God forbid if she missed that one day and had to get back in line for another 2 to 3 months to see the specialist. Those are things that I'm afraid of, as well as the upcoming funding cuts. It will create a lot of disparity to patients and employees, and patients like Carol James and health centers across the state, and resources that patients like Carol James depend on. And we need more short and long-term funding to protect these patients and clinic employees. Because we'll be right back at this at 2016, and a lot of patients depend on their neighborhood clinics for their primary care, for their physicals, for their kids. And we are at the front line of this battle of making sure everybody has health care and the support from the Affordable Care Act. So I hope you guys really, thank you for this hearing, to get the dialogue going about the disparities, and thank you.
Thank you. And who would like to go next?
Okay. Hi, I'm Pashi Michelson. I work for NorCal Mental Health America, and I am the project director for the California LGBTQ Reducing Disparities Project, which is funded by the California Department of Public Health using Mental Health Service Act dollars. I also want you to know I brought you all a present for the end of the day, and thank you so much for letting us do public comment. I have a copy of the report for each of you that I'll give your staff member. I'm here because we have this Western notion that we should separate mental health from physical health, as if our brain is not part of our body. So just as there are social determinants of health, there are also social determinants of mental health. And living in an environment of minority stressors, such as rejection, discrimination, stigma, and prejudice, negatively affects a person's health and mental health on many levels. The research from our Reducing Disparities Project indicates that the most rejecting social supports for LGBTQ Californians are their place of religious worship, their racial and ethnic communities, and their family. The most rejecting providers are their primary care providers and nurses and nurse practitioners. Providers that answered our survey reported that the top barriers to providing culturally competent care for LGBTQ clients is a lack of training. We also found that that lack of training is a barrier to providers asking their patients and their clients about their sexual orientation or their gender identity. Not asking about sexual orientation and gender identity keeps LGBTQ people invisible, essentially. And we have been told that funding is a barrier to collecting such data, as well as the lack of training. Not funding the collection of sexual orientation and gender identity data sends the message that LGBTQ people have no value. For all the reasons we collect race and ethnicity data, we need to collect sexual orientation and gender identity data. For all the reasons we value diversity, we need to extend that value to LGBTQ. Thank you so much, and for more information, look at the report.
Thank you very much. Appreciate it.
Good afternoon,
Good afternoon.
co-chairs and members. I'm Joe Michael for Equality California. Thank you again for convening this hearing, and we're glad to be able to be a part of it. I would just like to quickly echo statements made throughout the hearing and now during public comment, and in the background paper as well, about the importance of addressing health disparities in the context of lesbian, gay, bisexual, and transgender communities. In particular, Assemblymember David Chu's comments regarding his bill, AB 959, of which Equality California is proud to be a sponsor. I'd like to highlight the importance of collecting data on sexual orientation and gender identity in the context of all health data. In particular, the CalHEAR system, which was discussed quite a bit today, and includes Covered California and Medi-Cal, and therefore covers 1 in 3 Californians. That's an example of a great context where sexual orientation and gender identity data would make a tremendous impact. So that's an important thing we hope you all will keep in mind as we move forward. We really need to understand the extent to which LGBT people are experiencing disparities in health and well-being, and whether government programs are reaching LGBT people in need of care. And we've learned that if we are not counted, we do not count. So we just wanted to add those comments today, and thank you.
Thank you very much. Seeing no other interest for public comment, no other questions from any of the members, I'd like to thank all of you, including those who came up on public comment, for being here today, and we are adjourned.